Somebody asked me yesterday about glycation from fructose. We know that fructose has a glycation potential of 7 to 10 times greater than glucose. And the question was, how do we test it in pathology? And I was like, I don't know. I know that it might be reflected slightly in HbA1c, but it's certainly the dominant influence on HbA1c is glucose. Is there any tests we have for fructose glycation, especially considering, and I think this is just an important point, that people, when they have diabetes and they have higher blood sugar levels, there's a pathway that converts glucose to fructose. It's called the polyol pathway, and that can convert up to about 30% of glucose to fructose.
That's a great question, as I would expect. The fructose levels in the blood are like 1,000 times lower than glucose levels. The body does not want high fructose levels in the blood. They're micromolar level. But they do attach, as you say, it does attach. And when we're measuring hemoglobin A1c, we're focused on the A1c measure, which is glucose stuck to hemoglobin. But hemoglobin A1a and A1b are other adducts. And I'm pretty sure hemoglobin A1b is the fructose 1,6-phosphate adduct of hemoglobin. So we can get a measure in those labs running electrophoresis that capable of separating hemoglobin A1b. That would be a measure of persistent elevations of fructose. But yeah, it seems like the body does not want fructose in the circulation. And that's why it quickly converts it to fat in the liver and doesn't really let it out. Look, the LDL profiling, I'm telling you that you don't need it. The total cholesterol HDL ratio tells you most of it. But I do find it's a really powerful thing for patient engagements to actually see things change in response to the diet. They're seeing the scales change, they might see their blood pressure change. They just like to see the numbers, the biochemistry, which doesn't lie in any way. They like to see those changes. So I do like it when you've got a patient who needs that extra motivation to show them they're in a bad place and show them a good place that they've got to. But otherwise, I don't really think it's worth the money for the analysis. I'm pretty happy with what we've got there. There are tests for oxidised LDL and glycated LDL. They correlate almost perfectly with small dense LDL, and they're predicted by total cholesterol HDL ratio, so I wouldn't do that. Hemoglobin A1c, I'm a big fan of. I did a YouTube on hemoglobin A1c. I think that everyone should know their hemoglobin A1c. It tells you how healthy you are or how close to diabetes you are, let alone whether you've got diabetes. So that's the most underestimated test. I've been saying for years the test that I've been hanging out for is a test called lipoprotein-associated phospholipase A2, which is a test that's available. Now, what it is it's a protein made by macrophages in the plaque when they're eating LDL. So it's like a measure of plaque activity, a pure measure of plaque activity rather than an indirect measure like high-sensitivity CRP and so on. So I'm hoping, now that I've moved to the new lab, I can talk them into, because it's available on a routine analyzer. And I'm hoping that'll be available, and it will be a cheap test because it's a colorimetric test, so it shouldn't cost hundreds of dollars. It should cost like $10 or $20. And I think that would be a game changer for people looking for confidence that what they're doing is helping their atherosclerotic activity. Great questions. Yeah, PLA2 will get you to the literature on that. All in capitals, PLA2. You didn't have to remember the whole name.
I wanted to ask just about the impact of sex differences on lipid profiles, and I became interested in this after I'd had my second baby, and my GP said to me, your cholesterol's quite high, and I was like, well, you try growing a baby without cholesterol. So when is it more optimal, perhaps, in the menstrual cycle for women to get a lipid profile that might accurately reflect their levels, or is it not relevant?
Theoretically, it'd be better in the follicular phase, in the first part of the menstrual cycle, because in the luteal phase sort of mimics pregnancy. It's got high levels of progesterone and there's hyperventilation. There's a whole lot of things happening in the luteal phase. So overall, I'd probably if I was doing a research study, I'd probably suggest doing the follicular phase. And that issue about pregnancy is really important. An average cholesterol in the third trimester is about 10. And the average triglyceride level in the third trimester is about 5 or 6 in healthy women. So, they should have all been dying of heart attacks. But in pregnancy, you are shuffling energy to that baby and cholesterol. And so, it's a good example of how important those blood tests are really about energy metabolism rather than anything to do with heart disease.
Ken,
yes, sorry.
So good. LP little a, can you talk about that? That's such a big topic when you hear the Americans go on.
Yep. There's a lot of interest in LP little a because there's now some antibodies that can influence the levels, and they're really interested in whether that's going to change outcomes. But we're still learning. I'm hoping those drugs will teach us a little bit more about LP little a. LP little a is a form of LDL. So there is such a thing as small, dense LP little a. Generally, if you've got small, dense LDL, you also have small, dense LP little a. Now, your gut feeling is if LP little a is bad, small, dense LP little a might be even worse. So that's a really interesting area. And it's such an interesting area, Grant. I was thinking I really need to do a talk on LP little a because it tells you a lot about the pathogenesis of cardiovascular disease, as well as more and more people are getting it measured, and there are some traps in the way the laboratories measure it as well that we need to discuss. But it's a big topic. It's a genetically determined risk factor, but whether it's modifiable in its atherogenicity is a big question that needs to be answered.
I just wanted to ask reference ranges
yes.
that labs set.
Yes.
What are they based on, and do labs ever talk to each other?
It's an incredibly good question. Now, I'm on, believe it or not, the International Federation of Clinical Chemistry's Committee on Reference Intervals and Decision Limits. And that mouthful also tells you that there's two things, reference intervals and decision limits. The numbers we put next to your results may be a reference interval, so the usual spread of results in healthy people. That is a different parameter to a decision limit. In a way, the reference interval is like based on specificity. Like if you belong in the reference interval, you're likely to be healthy. It doesn't tell you anything about your likelihood of disease. Whereas a decision limit is based on sensitivity. And so the decision limit is based on maximum sensitivity. So with if you had a reference interval for total cholesterol, it would be 3.8 to 7.8. And people get freaked out about their cholesterol level being 6. That's completely typical of an Australian. But the cutoff that we put on the report is 5.5 because according to the older studies, as soon as you'll get above 5.5, which is, guess what, the middle of the reference interval, as soon as your total cholesterol is above average, well, guess what, your cardiovascular risk is above average. So they're different cutoffs, and now labs are talking to each other. We have discussed things like how we report lipids. In an Australian community, we have meetings once a year, and we got about 100 people representing about 100 labs that get together. And we actually decided in one of the meetings that we shouldn't report total cholesterol. It's so rubbish that we shouldn't put it there, let alone put it at the top of the report. One lab was brave enough to remove it from the report, and they got 100 phone calls saying we want the total cholesterol. So even though we know that's what we should be doing, we're also satisfying both the patient who wants to see the total cholesterol and the clinicians who are 30 years out of date and looking at the total cholesterol.
I'm just wondering how you find out if you have familial hypercholesterolemia.
Yes.
I have ridiculously high cholesterol and LDL, like over 15 total and over 13 LDL.
Yep.
How do I find out if I have familial?
It's very easy. The government introduced a Medicare rebate for testing. All you have to do is satisfy the criteria, which is something like an LDL level, which is persistently above 5.5. There are some other scoring systems. We've got a family history, a past history, and something adds to the score. But generally, if you've persistently got a cholesterol above 10, you qualify to have the genetic testing done. No, that's right. So, yeah, it's $1,200. So the reports should all say that. The laboratory reports, when your LDL is above 5.5, should have a comment below to saying that this patient may qualify for genetic testing for familial hypercholesterolemia, and that you need to be referred to a specialist. That's a cardiologist, endocrinologist, lipidologist, doesn't really matter who, but a specialists are allowed to order that. And we do want people to be tested. And I'm also intrigued for people to be tested who are lean mass hyperresponders, because we want to understand their genetics as well. Yeah, they should order it if you've confirmed and satisfied those levels. You should ask them for that. Yeah.
Ken, just before you go, I'm sorry, we have one late question from the live stream. Do you see growing rates of normal TSH but elevated levels of antithyroid peroxidase?
Antibody. Yeah, no, it's a good question. The thing that people don't realise, and this might be a left bank talk for low carb down under, there's this fascinating thing called feto-maternal microchimerism. I could talk for a day on it. It takes almost as much to explain as to pronounce, but a mother and a baby exchange cells in pregnancy. Every mother here has got the cells of her baby in her body. Every person here has the cells of their mother in their body. That is the core of autoimmunity. Now, women, particularly if they've had pregnancies, have 30 to 40% of them have thyroid antibodies. 30 to 40%, because the fetal thyroid cells, for some reason, are very, promote the generation of these autoantibodies. Now, clearly, 30 to 40% of women do not develop thyroid disease. Things can go wrong with that, and they develop thyroid disease. So antibodies on their own are meaningless, particularly in women in their 30s and 40s, i.e. women who've had a pregnancy. So we do not think that 30, 40% of women should be on thyroxine. We use the TSH as the judge. And it is true that women with thyroid antibodies that are elevated are more likely to have a slightly higher TSH level. But you shouldn't treat that, because there's real risks in giving thyroxine when it's not required. The risk is thyroid hormone increases bone turnover. And the last thing you want to do in a woman, particularly after the age of 30 or 40, is to make the bones any weaker. So the risk of over-treatment when there's unnecessary treatment is really why people try to avoid thyroxine therapy, particularly in people that have only raised antibodies or mild or higher than average TSH levels. Now, there are lots of clinicians who would be happy to prescribe you thyroxine when your TSH is perfectly normal and your thyroid antibodies are elevated. Look, you'll probably feel better on it, but please make sure you don't get over-treated, because then it'll be doing you more harm than good.